The aim of this GP Cert Cardio is to really give you a broad education in cardiovascular disease, from the real basics through to a much more advanced level. And I'm really proud to have put together an array of speakers from diverse backgrounds with very sort of broad interests, who represent leading clinicians, leading researchers in the cardiology field. Every one of them is a residency trained diplomat. Every one of them is a really great speaker. So I'm really pleased to have them on board. Anyway, over to this evening's session. In this session, we're going to talk about managing the emergency patient. So we're going to focus on dogs, and we're going to think about beyond furosemide therapy. So our aim here is not to say to you, you've got heart failure, give it furosemide, maybe pimobendan, okay, they get better, they go home. That's what most dogs are like. We are going to focus on what I would think of as the emergency patient. Most heart failure walks into the clinic, you identify heart failure, they walk home again. I'm talking about patients that are really much sicker than that. And with their heart failure, they require oxygen therapy, hospitalization, stabilization. And we're going to pick up at the point where we give furosemide and it doesn't work. And these are patients that you will see. These are patients that I'm going to hopefully provide you with some tools here to reach for in your toolkit to help these dogs. So our aims, we're going to briefly mention pathophysiology of acute presentation. We're not going to focus on that. We're going to focus on treatment option beyond intravenous furosemide and oral pimobendan. And we're going to mention along the way endpoints and when to consider, actually, we can't help them. We can't fix everybody. So these are patients where we need to consider euthanasia. So we're defining heart failure as a clinical syndrome caused by fluid accumulation. Now, most of the cases that we're talking about in the urgent patient are pulmonary edema, pleural effusion. Ascites is rarely so urgent that we need to do something right now. I did last week drain a large abdominal effusion in a dog who was breathless because of the abdominal effusion, not sleeping well, because of the pressure on the diaphragm. So in those situations, I would perform abdominocentesis, but I don't consider it an emergency. It may be a priority. And if you're going to perform abdominocentesis, don't drain them dry, because you risk electrolyte shifts and protein loss as they reeffuse a large volume. It's sometimes helpful to leave a little volume there to help support that sort of systemic homeostasis. So I drained 1 litre from a Newfoundland dog who probably had 4 litres in there. So I think if you can drain 20 or 30%, that's sufficient to relieve the pressure on the diaphragm, help the patient, and not risk systemic consequences of large volume centesis. So we're going to focus on pulmonary edema, pleural effusion, and really we're going to focus on pulmonary edema, because we all know that if we identify pleural effusion, how do we treat it? Well, we drain it. So acute heart failure signs: tachypnea, dyspnea. Coughing may be present in some patients with acute heart failure. There's a little controversy surrounding cough, but the short version of the story is that some dogs with pulmonary edema will cough, especially if it's quite severe edema, quite acute. It seems to help activate mechanoreceptors, which cause coughing. And if we treat them with diuretics, that will go away. Now, don't use the cough as something to monitor. Do not treat the cough per se. Treat for respiratory rate, treat for comfort, treat for respiratory effort. If they're still coughing, well, they may have respiratory disease associated with their heart disease. They may have primary airway disease, airway collapse because of cardiomegaly, promoting the cough. So don't give a dog that's got normal respiratory rate and coughing lots and lots and lots of diuretics. They're not going to benefit from that. You need to think about why they're coughing, because if they've got a normal respiratory rate, it's not pulmonary edema. So some of the worst patients will have orthopnea, where they adopt a posture like the dog in this photograph. We can see this dog has got his elbows adducted, neck forward. He's in an air-hungry posture that minimizes dead space for him. The poor guy had very bad dyspnea, and sometimes these patients are really quite distressed as well. They're short of breath. We all know that if that happens to us, we feel distressed. Effectively, these are patients that are drowning in their own pulmonary edema. DCM, mitral valve disease. They are similar enough in their outcome causing heart failure that we can effectively treat them the same. But there are some particularities with these more acute patients when we've given them furosemide and pimabendan and it's not working. So the typical presentation for a patient with dilated cardiomyopathy, they're usually large breed dogs or giant breed dogs like the Great Dane, Newfoundland, Doberman, Boxer, Dalmatian. The exception to that rule is the Cocker Spaniel. We see Cocker Spaniels often with dilated cardiomyopathy. They also get mitral valve disease, so do bear that in mind. They're often middle-aged older dogs. The exception to that rule is the Portuguese water dog. We don't see many here in the UK, but the Portuguese water dog has a juvenile autosomal recessive form of dilated cardiomyopathy. So they may be young animals presented with bad heart failure. That doesn't mean it is a congenital disease. Most of these patients have pulmonary edema, and arrhythmias are pretty common. So atrial fibrillation is common with atrial dilation, but also ventricular arrhythmias in these patients because it's a primary myocardial disease that's leading to fibrosis, ischemia, damage to the heart muscle, which promotes arrhythmiogenesis. And the ventricular arrhythmias in some patients are fatal before they ever show heart failure signs. So here's an echo of this actually I think was a Cocker Spaniel who has left atrial dilation. Mitral valve is here. The left ventricle is very rounded looking and is also hypofunctional. Some of these dogs do have mitral regurgitation. So we can see here we've got a jet of mitral regurgitation shown on the coloured Doppler in the centre. And here is an echo in short axis of the heart showing the left ventricle again with dysfunction. If you're in a room with the lights on like I am right now, then you may not see this very clearly, but if you dim the lights, you should see the echo a little bit better. This echo is not perfect. This is all one case, it's all a real case. You know, I didn't need to align it perfectly to say the function was very poor in this dog. This is an M mode, motion mode, looking at the left ventricle. And what we're doing is we're looking across the short axis of the left ventricle here, looking at wall motion. So this is the septum up here, the left ventricular lumen or cavity, and the left ventricular free wall. And the bright white line is the pericardium here. So we see the walls should move together during systole as the heart contracts. And it's not moving together very much here. We can see that you know, this diameter in diastole should shorten by about 25 or up to 40% compared to the diastolic diameter. It should shorten by that much during systole. And here it's shortening by maybe 10%, 8%. So this just confirms using a numerical value what we had assessed on the global view of the heart. So very poor function. And here we have the aorta in the middle and the left atrium to the bottom left of the screen. This is the auricle here. And this left atrium to aortic ratio, so that the aorta is our sort of standardizing factor for body size. The left atrial size should be no more than 1.5 times that aortic diameter. So that should take us to here. Here we're approximately 2.2, something like that. So this is significant left atrial dilation, which is almost universally present in dogs with bad heart failure signs. This is a thoracic radiograph, a lateral projection of the thorax. And it's not one that I took. I'm saying that because I would never recommend taking a radiograph of a patient who is this dyspneic. This was a case where I came in to work in the morning and an intern said to me, oh, hey, I wouldn't mind your opinion on my patient. I took some radiographs. Can you have a look? Tell me you think it's cardiac. And I didn't look at the dog first. So I went and looked at the radiographs. And I said, wow, certainly was cardiac, thinking this guy would be dead. I said, what did he look like when you took the radiographs? Oh, he was really dyspneic, 8-year-old Doberman, coughing, pink-tinged fluid up. I wouldn't take a radiograph in that dog. I would presume that dog had dilated cardiomyopathy causing heart failure and treat with furosemide. I was convinced this dog was probably, you know, worse for having radiographs and being stressed out in lateral recumbency. And I said to the intern, well, how is he now? Slightly worried about what I was going to hear. And actually, the dog was asleep in a kennel, having responded beautifully to furosemide and pimabendan therapy. So you can see here, there is cardiomegaly. I promise my coughing is a chronic cough. It's nothing to do with corona, although I'm isolated, so Who cares? You can see here we have a very dense alveolar pattern, so dense you can't really see the caudal margin of that cardiac silhouette, nor can we see the caudal vein cava, because the alveolar pattern is so dense in these lung lobes, and it extends cranially as well. We can see these air bronchograms branching off here. You don't need to take a radiograph to confirm heart failure if your patient looks as bad as this guy did. But I'm showing you what it looks like on a radiograph. Now, if you have a dog presenting with acute heart failure signs, especially with dilated cardiomyopathy, they're often hypotensive. And many people would say we should not give diuretics to a hypotensive animal. I would argue that we should if it's in heart failure. Now, the theory says that if we reduce circulating volume by giving diuretics, we will further reduce cardiac output. And if we further reduce cardiac output, we will promote hypotension-induced renal injury. Another good point is that furosemide will not work very well if renal filtration is not normal. So it works on the tubular side of the receptor in the ascending loop of Henle. So it has to be filtered at the glomerulus. And the theory is that if you have hypotension, your GFR is low, therefore your furosemide response is low. That latter point is absolutely true, but I would argue that what else are you going to do in a patient with heart failure? We are going to really struggle to improve that GFR and get that furosemide to work if we don't give furosemide. Now, what we're forgetting, thinking about the first 2 points here about hypotension and cardiac output and renal injury, what we're forgetting is that when we think about cardiac output, we think about physiology. So we know that as preload increases, cardiac output increases. The sarcomeres will stretch. That will promote more cross-linking at the sarcomeres and a better contractile force. We all learned that when we were 16, 18 years old. Maybe we forgot it, but it's come back since, okay? So if you increase preload, increase stretch, you increase cardiac output. So in the physiologic range, if you give a diuretic to reduce preload, you will reduce cardiac output. That is true. For the dog in heart failure, we are not in the physiologic range. We are in the pathophysiology. We've gone beyond this. The preload is so high because of RAS activation that the sarcomeres are not at their optimal stretch. They're stretched too far. They no longer overlap enough to generate good contractility. So in the acute heart failure stage, this physiology has gone wrong. If we reduce preload by giving diuretics to acute heart failure, we will improve that sarcomere stretch and optimize it, and we will increase cardiac output. Therefore, we will not promote hypotensive renal injury. We will improve the outcome of these heart failure patients and actually increase blood pressure because of giving diuretics. So what's considered a poor response? When do we need to reach for these things beyond furosemide? So I said we're giving furosemide, we're giving pimobendan. If you give 6 to 8 milligrams per kilo furosemide over 2 to 4 hours, that's not a very good response. Or if we have a deterioration despite furosemide in the first 1 to 2 hours, that's when I would consider reaching for additional treatment. So how do we manage the non-responders of dogs with dilated cardiomyopathy? Well, we need to improve cardiac output, which will increase tissue perfusion, increase GFR, which will make the diuretic work better. So we also need to reduce left atrial pressure, because if we can improve forward flow, we'll drop left atrial pressure, and therefore we will reduce the driving force for pulmonary edema. So we're going to try for this improved diuretic response. How can we do that with dilated cardiomyopathy? Well, the first port of call is dobutamine. And dobutamine is a drug which will increase cardiac output. So this is a racemic mixture of isomers with dextroisomer and levoisomer. The dextroisomer is a strong beta-1, a weak beta-2 agonist, and an alpha-1 blocker. The levoisomer is an alpha-1 agonist, which balances out that blockade in the first isomer, and a weak beta-2 agonist. So overall, when we give dobutamine, we have strong positive inotropic and chronotropic response caused by the beta-1 agonist effect, and we have a very weak vasodilatory effect to some of the muscle beds using the beta-2 receptors, which are present in dogs. So we'll actually help to increase tissue perfusion and increase cardiac output by using dobutamine. So here we're thinking about the interaction between cardiac output, heart rate, and stroke volume. So the reason I've done it in a triangle like this, if you cover up the cardiac output, you can see cardiac output equals heart rate times stroke volume. And if we cover up the stroke volume, you can see cardiac output is dependent upon heart rate. So when we've got a fixed stroke volume or reduced stroke volume like DCM, heart rate is really important to maintaining cardiac output. If we can improve stroke volume just a little bit by giving a positive inotropic response using dobutamine, then that will also improve cardiac output. This is absolutely life-saving for dogs with bad dilated cardiomyopathy. And we started a dose of 5 micrograms per kilo per minute. The negative effects of this, well, it increases how hard the heart has to work. And this heart's already failing. It increases oxygen demand. And potentially, because of various changes to the myocardium and the way calcium cycles through the cells, we get an increase in intracellular calcium, which can cause little explosions of calcium in the cell, which can be pro-arrhythmic. So if you give dobutamine and you develop arrhythmias, that is a contraindication to continuing, or at least increasing the dose. So how do we monitor? Well, you've got to have a continuous ECG because we know it's pro-arrhythmic, and therefore if we are saving the dog's life by improving its tissue perfusion, reducing its pulmonary edema, but giving it horrendous life-threatening arrhythmias, that's not really okay. And what we tend to do is monitor blood pressure as we're giving it. So we'll start them on 5 mics per kilo per minute. We'll walk away for 10 minutes or so, come back, check how they're doing, check respiratory rate, check blood pressure. And we might increase the dose then. If there's no increase in heart rate, that means the dobutamine is not working. So we need to increase the dose again. And I will increase it up to 10 mics per kilo per minute. I don't tend to go above that because it doesn't tend to work anymore if you give 12 or 15. If we get ventricular arrhythmias on a new dose, reduce back to the previous dose, okay, and see if we can just support them using that. After 48 hours, they begin to develop tolerance to dobutamine. So it's not going to help them after 48 hours. And what we tend to say is after 24 hours, if there's no improvement, they will not get better. So it's pointless continuing it for longer than 24 hours or increasing the dose after 24 hours. Another continuous rate infusion we can use is furosemide. And I really like using furosemide in dogs with bad heart failure signs. Obviously, I like using furosemide. I'm a cardiologist. I like using it as a continuous rate infusion. It's a little bit more hassle to set up. It takes a little bit of time. The nurses get a little worried if they don't use it very often. But it's something that we can become more familiar with. To the left here, we have a diagram that shows you the effect of bolus therapy. So the boluses of furosemide increase the concentration within the therapeutic range. And then it drops down below the therapeutic range again after a few hours. Furosemide lasts about 6 hours, although we only give it twice a day in most cases. We can give it much more frequently in the acute patient. So this gives peaks and troughs of diuretic effect. And when you give a continuous rate infusion, we always give an initial bolus, but the continuous rate infusion will slowly creep up into that therapeutic range and maintain a fairly even concentration. So the peaks will not be as high as bolus therapy, but the area under the curve may be equivalent or even greater to bolus therapy if you give a continuous rate infusion. And it's quite neat because sometimes we can put them on it and just let them receive it, and you don't have to keep opening and closing oxygen kennels to administer boluses, which can help with your fraction of inspired oxygen. Now, I like to give this in a hypertonic solution. So we give a diuretic in a hypertonic solution. Now, we all know that if you give hypertonic saline, it increases intravascular volume, which is bad because we're trying to reduce intravascular volume using furosemide. So this seems counterintuitive. But actually what happens is the hypertonic solution that you put this in will go through the lungs in the pulmonary vasculature, and the hypertonic effect will have a suction effect to pull out the liquid from the interstitium, which will briefly expand the intravascular volume, but then because there's diuretic there as well, they pee out that extra intravascular volume. So this has a rapid effect to bring fluid out of the lungs just by osmosis. And then we increase urine output with the the furosemide. This has been proven to be safe and actually reduce RAS activation compared to furosemide given in an isotonic solution. So we think that isotonic is good, but actually it's not. Isotonic solutions might increase RAS activation to make the situation worse. So the hypertonic solution is helpful. It's a little bit more challenging to set up, but that's okay. We can work around it. We're clever people. Here's my terrible handwriting. The reason I've included that is really just to prove that I do work in a clinic, and I have sick patients and I have to scroll on the notes to think it through every time. So to make up the furosemide CRI, I use 100 milligrams furosemide, which is 2 mils of 50 mg per mil solution. Then I put that in with 15 mils of hypertonic saline and 30 mils of 5% glucose saline. Okay, this is what the Americans call D5W, dextrose 5% in water, which effectively is like giving free water. So we're reducing how hypertonic the saline is by giving free water, and we end up with a solution that I think has around about a 2.5% tonicity compared to hypertonic, which is more like 7. Okay. So with this, we end up with a solution that contains 2.2 milligrams of furosemide per mil. So we begin by infusing that at 0.66 mgs of furosemide per kilo per hour. So this is a dog who weighed 7.6 kilos, multiplied by 0.66 was about 5 mgs per hour, which for this dog was less than 1 mil per hour. Per kilo per hour. Okay, so this was around about 0.3 mils per kilo per hour. So that's pretty good, okay, because we're not giving a lot of fluid by using this concentration of solution. So the magic numbers you need to remember: 100 milligrams of furosemide in 15 mils of hypertonic saline and 30 mils of 5% glucose saline, and then the rate is 0.66 mgs per kilo per hour. That is your starting rate, and you can increase it from there. What are your endpoints? Well, positive endpoint, we see a dog where we have dobutamine and furosemide CRI. We wean them off the dobutamine after 24 hours. We have a reduction in respiratory rate. This dog is doing great, tolerating furosemide orally, tolerating pimabendin orally. They're eating. Potassium is within reference. It's amazing. This dog's ready to go home. Negative endpoints, well, if they're on dobutamine at 10 mics per kilo per minute or a lower dose and they develop ventricular tachycardia, then we can't increase the dose any further. And maybe the respiratory rate is still very high and we can't control things, in which case we probably have to call it quits. If we can't wean the dobutamine after 24 hours without increasing respiratory rate again, then that is something which would be a negative consideration. This brings me to a point of, why are we bothering to give a 24-hour continuous rate infusion of a drug when we've got a chronic degenerative disease? Because surely we give the 24 hours, we take it away again, the dog's back to where they began. Well, they're not back to where they began. Because if we have an acute worsening of function that causes congestive heart failure, this dog can increase their lymphatic uptake to increase fluid uptake in the lungs by 20 to 50 fold. That is huge. So the other thing is that the left atrium increases pressure, causes heart failure, but actually as that pressure pushes on the walls of the atrium will stretch to get a little bit larger to accommodate the pressure within the atrium. So actually the pressure will reduce, which reduces the drive for edema. So sometimes we just have to keep the dogs alive long enough for them to cope. So the way that we see this treatment in our clinic is this is a bridge to get us to a better situation for the dog and allow time for oral medication to work. So we're just helping them across that rough patch of sea until we can get them safe. Okay, it doesn't work for all dogs. The bridge isn't long enough for all dogs, or some dogs aren't strong enough to cross it, but we just need to put the bridge there to help them get across the dangers of the acute heart failure. Mitral valve disease. How can we manage mitral valve disease beyond furosemide therapy? Well, typical presentation. Oh, I have to say, I included this picture of a Chihuahua who wore a picture of himself on his collar it's just incredibly arrogant behavior from that dog, really terrible. Typically dogs with mitral valve disease are small breed dogs. The Chihuahua is one. We see lots of Cavalier King Charles Spaniels, terrier breeds. Any old small breed dog could be affected by mitral valve disease. The exceptions to that, we do see mitral valve disease in Labrador Retrievers sometimes. That can be 25, 30, 40 kilos. Border Collies, 15 to 20 kilos in body weight normally. These guys are a little bit larger, but they do have mitral valve disease as a genetic predisposition. Nowhere near as common as in the Chihuahua or the Cavalier. They're often middle-aged to older dogs. It can be diagnosed in youth, but that is the exception. And oftentimes they will present with pulmonary edema. They can develop arrhythmias, but they're much less common than in dilated cardiomyopathy. And mostly it's atrial fibrillation because of stretch to the atrium. So here we have an echo image. Again, dim the lights. If you're in a light room like I am, you'll see better. We have a large left atrium here, left ventricle here, and the mitral valve in the middle. It's thickened and distorted looking and is prolapsing, bending back, pointing towards the roof of the left atrium during systole. Here's that valve slowed down. We can see, you can almost see the hole in the valve here, can't you? Where the valve really doesn't meet. This should close fairly straight, and you can see how it bends backwards like a parachute as you take the air. This is the short axis of the left ventricle. It looks quite different to dilated cardiomyopathy. It's moving very well compared to DCM. And here's the left atrium to aortic root ratio. So the aortic root in the middle, left atrium should be no more than 1.5 times that diameter. So the left atrium should come to here. I mean, clearly it's about 2.5 or 3 times the diameter. This is a large left atrium. And here's that M mode of the left ventricle. We can see the ventricle's moving well. It's actually moving too well. This ventricle's having an easy time because not only is blood going forwards through the aorta into the high pressure systemic circulation, it's also leaking backwards in huge volumes into the left atrium, which is low pressure. So the ventricle moves a lot. So it's quite hard to really assess the function of the ventricle in these guys. A number of them with bad heart failure will have systolic dysfunction. Here's a radiograph showing very early heart failure compared to the last radiograph. We see a large left atrium here and a little sort of interstitial alveolar pattern in these chordodorsal lung fields and some distension of the pulmonary veins compared to the arteries. This is, these 3 things are suggestive of left-sided congestive failure. So in most dogs, we give furosemide, pimobendan. We know how to treat that. How do we deal with poor responders? Well, one thing we can do is reduce the severity of mitral regurgitation. We talked before about increasing systolic function to increase cardiac output in DCM. We can do that in mitral valve disease, but actually this is a much more effective way than using dobutamine alone. Sometimes we will use dobutamine in addition to the methods we'll describe now. And of course, improving diuretic response with a furosemide CRI is a valid and useful thing to do in these patients. So how do we reduce the severity of mitral regurgitation? Well, let's think for a moment about the pathophysiology here. If we think about the pressures in the left ventricle, the left ventricular systolic pressure is about 120, 130 millimeters of mercury. Aortic pressure that we have to overcome increases in systole about up to 120 millimeters of mercury. So that's what the ventricle is pumping into, is a relatively high pressure aorta. The left atrium, the pressure is very variable. In heart failure, we might be at 25 millimeters of mercury, maybe 40 millimeters of mercury, but it's still much lower than what we're pumping into for the aorta. So lots of blood will go backwards into that left atrium. And I just guessed a number here and said that the mitral regurgitant fraction is about 60% of stroke volume. It can be even higher in dogs with bad mitral valve disease, which is a huge amount of output that's not really going out, it's reversing into the left atrium. If we can drop systemic blood pressure, then actually we can improve that situation. So if we reduce systemic vascular resistance, we drop the afterload on the left ventricle, we drop the pressure into which the ventricle has to pump. And that will improve forward flow, because what happens is more blood goes forward because it's easier to get blood out of the heart, and less goes backwards. We might drop that to a 40% regurgitant fraction, say, and therefore we reduce left atrial pressure from 25 or 30 or 40 down to 15 millimeters of mercury. Okay, so in this example, we can see that by dropping blood pressure means more blood goes forward, less blood goes backwards. How do we do that? Well, we use a drug called sodium nitroprusside, or abbreviated here to SNP. I often just call it nitroprusside. This is a nitric oxide donor. So what it does is it goes off into your peripheral vasculature, into your arterioles, your resistance vessels in the vascular tree, and donates part of its chemical structure to cause nitric oxide production. Nitric oxide in the vessels is a potent vasodilator. It's a dissolved gas which causes vasodilation. So this is an arteriodilator and a venodilator. So what it does, as well as reducing afterload on the heart, it also means more blood will sit in your peripheral vessels, which takes it out of the central circulation of the heart. So more blood sits in your splanchnic vessels, in your gut, in your spleen, for example, and less blood comes back into the left atrium, and therefore that will help to reduce left atrial pressure too. So it has a double effect in that it reduces preload, reduces left atrial pressure, and it reduces afterload, which is systemic arterial pressure. So this double effect has a huge benefit in terms of reducing mitral regurgitation and reducing left atrial pressure, and it is fast acting. Practicalities. Well, if they're hypotensive to start with, you don't want to drop their blood pressure further because you can cause renal injury. We dilute this in 5% glucose saline, so an isotonic solution here, D5W, if you like the American terminology, has to be protected from light. So we import it here, you see, from the EU, and it's in a brown bottle because it needs to be protected from light. And we tend to start at 1 mic per kilo per minute. I'll be honest with you, I often now start at 5 because many of them don't respond to a 5. So I start at 5, and if it's too profound a response, I reduce it. Most dogs will need more than 5. So I start at 5 mics per kilo per minute. After 5 minutes, I check a systolic blood pressure. That can be a Doppler, or it can be an invasive arterial catheter. Sometimes we do that in a tolerant patient because it's just a bit easier than checking lots of repeat blood pressures. And if your blood pressure is not reduced to a target of between 80 and 90 millimeters per mercury, then we will increase the dose. So we just titrate the dose of SNP to effect. There is no maximum dose. We just increase till we see a drop in the systemic arterial pressure. So we target to 80 to 90 millimeters of mercury, and we dose to effect. This is what happens when I have to deal with this. I have to write everything out. I'm a very simple person. I'm a very visual person. I list it all out, work out my maths on the page like I'm in high school, and then I transfer a neat version onto the patient record for the nurses to look at, or the people overnight to review when they have to make more of this solution. I tend to try and make enough to go overnight for them, but if you can't, it's nice to leave the right instructions, isn't it? Make their life easy. So here's my close-up again. We've got sodium nitroprusside, 50 mgs in 100 ml. D5W, which is 0.5 mgs per mil. And if you start at 1 mic per kilo per minute, that's 0.46 mgs an hour, which in this dog was 1 mil per hour. Okay, so that's a really small dose of fluid for this dog. So even if we're adding furosemide CRI and even dobutamine, you can keep the volume very small, and you can keep it less than 1 mil per kilo per hour. So there's no point in giving lots of volume to these dogs because obviously we're trying to get rid of circulating volume. So here's some photographs of setting up furosemide CRI on the left here, labeled as hypertonic, and also sodium nitroprusside on the right, protected from light. And this is the slightly unfortunate dog who had bad heart failure and required these because of his mitral valve disease. You can see we protect the drip line from the syringe driver all the way down to the patient with the nitroprusside. And he had an invasive arterial cath, which meant that we could measure his arterial pressure without having to repeatedly open the kennel door. We could leave him in the oxygen, leave him with some sedation on board, let him relax, and we can titrate these drugs to effect without opening and closing the door and stressing him out. And you see here the start, his systolic blood pressure was 122. So plenty of room for maneuver to reduce that down into the 80s. So when do we stop SMP? Well, after 36 hours, it can cause cyanide toxicity. So we definitely want to stop it before that. So we will start weaning at 24 hours and make sure we wean it fairly rapidly over the course of a few hours to get that out of the system. And what I do is at 24 hours, I will reduce dose by 30% or 50% if they're quite low, reassess them 1 to 2 hours later, even 1 hour is fine, and then reduce the dose again by 30 to 50%, and then probably one more time before I stop the drug. And we aim to discontinue it within 4 to 6 hours. So they never reach that 36 hours of cyanide toxicity. Do beware of that. What if you haven't got nitroprusside? I don't get it in the UK. I have to order it in from abroad, or in an emergency, if we don't have it for some reason, I'll often phone around the local hospital, and they just sell me a vial of nitroprusside for about €30 or so. So it's not an expensive drug when we get it via that route. But if you don't happen to have it available, then you can use amlodipine, which is an oral antihypertensive drug. It's a peripheral calcium channel blocker, which causes vasodilation. It's oral, it's cheap, it's not difficult to use. We've all used it for other things. However, you can't titrate it to effect. So you can't measure BP after 5 minutes and increase the dose. You give the drug, you wait and see what happens. If they get hypotensive, you can't stop it. You just have to wait until it's out of the system. There are some alternatives to that. You could use hydralazine. That is a very potent arteriodilator. Their membranes go brick red in their mouth. Never use it alongside an ACE inhibitor, because that will almost certainly cause hypotension and renal injury. Or you could use prazosin, which is less potent than hydralazine, but has a similar effect. So what are our endpoints for mitral valve disease? Well, similar to DCM. Positive endpoints: controlled respiratory rate after weaning the nitroprusside, tolerating oral meds, eating, potassium within reference, and ready to go home. Negative endpoints: well, if they don't respond to sodium nitroprusside, we can't continue it beyond 24, 36 hours. Or if we try and wean it after 24 hours and the pulmonary edema comes back, we can't continue it to give them toxicity. So 24 hours is your endpoint with this drug. So what can we expect from these severe heart failure patients? Well, for mitral valve disease, once they've overcome heart failure, their average survival time is 12 to 18 months. When they get diuretic resistance, pulmonary hypertension, ascites, all these other complex signs, it's probably 6 months in terms of survival. Acute heart failure can do very well if we get them out of the hospital. In DCM, the survival time is a little shorter. The prognosis is a little bit worse, 9 to 12 months, and sudden cardiac death is more common. Once they develop things like atrial fibrillation, diuretic resistance, it's much shorter time. It's around about 3 to 6 months after those time points. So, summarizing heart failure treatment beyond furosemide. If we have acute dilated cardiomyopathy, use dobutamine as your bridge for the first 24 hours. In mitral valve disease, use nitroprusside as your bridge. You can add dobutamine to maintain the blood pressure to allow you to use higher doses of nitroprusside if you like. And also don't forget furosemide as a continuous rate infusion. That's a useful drug and avoids those peaks and troughs of diuresis, which in humans have been associated with an increased risk of renal injury. Now, most docs will do well using these protocols. I would say about 70 or 80% of them, I get them out of the hospital stable on oral meds, but not all do. So you must have very clear endpoints in your conversation with the owner to avoid disappointment with these cases.